All right, continuing on to try to get through the rest of this. Um, Typical teaching related to home care for corneal abrasion. That's pretty clearly covered in your book. Um, One of the biggest things, as you can imagine, is antibiotics. And early on, someone really has to be able to do antibiotics as often as every hour. So anything that would prevent them from being able to accomplish that or have enough support at home to do that for the first 24 hours is key. Um, and impact of Plavix on pre-op cataract surgery. Um, Obviously a lot of older patients need cataract surgery, and a lot of them are on anticoagulants or antiplatelets because of other health issues that are going on. Um, a cataract patient should not have surgery if they have these type of drugs on board. So a surgeon's always got to review that and make the determination of when it should be stopped prior to the surgery, and usually that education is provided to the patient. So just making sure that they are aware of those restrictions before surgery. Um, I think most of you probably have figured out the reason that glaucoma is irreversible. It's just like many of our other things where somebody's the intraocular pressure is so extreme that it bears down on the blood vessels and the nerves in the eye, and creating damage because of poor perfusion, and damages them permanently. And so it's important when patients are being given the diagnosis of glaucoma that yes, some relief can be given to the situation, but depending on how long it's gone on, it typically is always irreversible damage that has occurred. Look in your book and go over kind of like how it talks about irrigating the ear canal. You can get some sensory weird sensations from doing irrigations and cleaning. The other things that are contraindicated that we teach patients is not to stick anything in their ear, because it can just cause more pressure, more wax pushed further into the ear, can cause irritations, and sometimes can even puncture the eardrum. So just be familiar with some of those things. Outcome goal for someone with hearing loss. Many patients with visual and hearing loss, as you can imagine, if you've ever had an elder in your family with either of those, they tend to be more reclusive, wanting to stay home, not wanting to be engaged in things. So when we talk about outcome goals, you remember how we talked about the big issue for that terminology is trying to make sure that really what would we really want this person to display that would give you an idea that they're really engaged in their surroundings and able to function fully, would be the kinds of activities and things that you would want to plan for them. Key assessment points for patient with rapid hearing loss who is older. Going through your book and looking at the assessment features, obviously, we're going to do an assessment of the inner ear first to look for wax buildup, because patients, the older they get, are not always as able to do cleaning in their ear. Other things we're going to look for is, have they had any damage to their ear? And older patients tend to be on, as we know, polypharmacy. So, lastly, kind of looking at could there be any medications that are causing this issue. But first and foremost, we always want to pay attention to the ear itself. Examples of the highest risk for noise-induced hearing loss. You just knowing that really heavy sounds, but again, repeated or really loud sounds, but repeated exposure and your age tends to make this even worse. So trying to find out what people really do in their life that may be contributing to this. Sometimes it's work related. Sometimes it might be a hobby that they have or something that they just don't happen to bring forward to you in the context of your assessment is important to really go after and ask more deep questions about. Um, let's see. Signs of ototoxicity. Make sure you're familiar with that term. What are some typical drugs that might cause ototoxicity? And what would the patient typically portray symptom wise? Risk of labyrinthitis. Your book's really clear on that. This type of inflammation and infection can progress to infection in the brain, so that's the biggest risk. And of course, damage to the ear and the hearing is really important too. Expected outcomes for a patient when their tumor is removed from the middle ear. Your book really goes into detail about how much the surgery may, benign tumors that are often in the middle ear that are removed, they may be fairly easily removed. They're not as likely to return or regrow back, which is a great finding. But if damage has been done to the ear and the hearing, it is not recoverable. So often they will have major hearing loss from the surgery being done. Typical complications for spinal fixation traction. You kind of think about what would you be looking for. Of course, we would be looking to make sure, is there any yellowish type of golden liquid draining, because that's the sign of spinal fluid. Is there, any kind of crusty infection type material? In that case, they would probably really need to have some of that cultured, report to the doctor and culture it just to see, make sure there's not an infection going on. And if you look down here at 37, the purpose of skeletal traction, really the whole thing is you're really trying to keep the whole spine in alignment. And so, anything that's going to detract from that, if your weights are on the floor, that's a significant issue, because clearly once that's on the ground, it's no longer providing the pull that it should for the traction. So that needs to be reported to a physician, because what if in the time that was not being pulled taut, something in the spine, pushed back together or caused some trauma to the spinal cord itself, which, can cause a lot of problems, breathing, cardiac, everything. So things like that you're paying attention to, if there's changes in sensation, what is the norm when you first have them put in it, and is there any changes in those frequent neurovascular assessments that you're doing. Let's see. We didn't talk a lot about in class about crush injuries, except to say that you all have kind of, I think, talked in the past a little bit about compartment syndrome, and have had some patients that have had that, probably some. But the biggest thing with that is you're really looking, as you can imagine, if a patient's telling you that, they've had an injury and now they're saying it's tingling, it's numb, it feels weird, your first thing is you're going to go immediately to check, what is the pedal pulses, or if it's an arm, radial, if it's an arm. You're going to really go check for pulses just to make sure, and if you need a Doppler, any of that kind of cut-off circulation can lead to compartment syndrome, and the only way to release that is for surgery to be done. Otherwise, they may lose that extremity. So circulation is everything with that, and looking for that. Highest risk factors that contribute to DVTs and fracture patients. Obviously, we know older patients that already have atherosclerosis, diabetics, patients that smoke, all those kinds of factors we've talked about in terms of impeding circulation are exacerbated even worse when somebody has a fracture, because again, they didn't have the best perfusion and circulation already, and now they're going to be laid up in the bed for a period of time or not moving a at one extremity or more, depending on what all's broken. Significant actions when crepitus is heard. We talked about that in class. The big thing you're going to want to do is, if that's not been present before, you want to make sure that the physician is made aware. And remember, crepitus is the sound bone on bone makes. So if you were, say, in the ER and you were hearing crepitus on your assessment of doing, an assessment of a body extremity, you immediately want to immobilize whatever that area is, because you don't know what you're grinding together. Okay, so that's kind of the things to think about. That, a patient might say, "Oh, that doesn't hurt," or that sounds like that all the time. So if they're able to participate and tell you some of that, then clearly. But if it's in the context of an injury or a car accident or any of those kind of things, again, immobilization is your first thing to take care of. We talked about cast. What do you do if the cast is swollen? It can be normal for that to occur. You can try, notify the physician. Of course, check your neurovascular checks in the extremity, the end of the extremity. Sometimes if it was an arm or a hand, you can lay that swollen extremity up on a pillow or two and get some of that to go down, and then it may be okay. If it is too loose, it's not holding the bone immobilized, and so a physician needs to be notified of that right away, because likely it's going to need to be replaced if it's, time, hasn't been on there long enough. Let me see. I think we've already talked about culturing pin sites. That would also be true for pin sites, not just skeletal traction, but also pin sites in the leg that we looked at as well. And we did talk about cleaning those with saline frequently to kind of keep that really cleaned and cut down on the risk of infection. First signs of a compartment syndrome, we've already discussed that. PCAs, as you can imagine, are used for lots of post-operative patients, but they also can be used for patients that have multiple fractures. And of course, all of us would want to have probably a PCA. Of course, that has to be logistical. If someone's got two broken arms, probably not. They're not going to be able to do a PCA and use it properly. So just consider that in the context of what kind of situation it is, because it's not always appropriate for everybody with multiple fractures, but many times it's the pain medication of choice to give the patient some control. PE, you all have remembered some of that in terms of extreme shortness of breath that kind of comes on rapidly and or may not go away, and of course, that can be not only like signs of a fat embolism, but just a typical blood clot can occur because of fracture and immobility also. So, what are you going to do if somebody's having symptoms of shortness of breath? You're going to probably put oxygen on and assess their lung sounds, and kind of be prepared that they may be having a PE until you can take them down for studies to rule that out. Activity limitations, again, post-op vertebroplasty may be your minimally invasive kinds of vertebra surgery. Some of those will go home fairly soon, but they are really, your book's real clear on that they are not to be doing but certain, activities. Make sure you're aware of those and which ones they cannot do for a period of time as well. What would you teach somebody when they're going home? Risk factors for the development of pericarditis, those are clearly outlined in your book, as are the elements of the heart failure core measure set. That's going to be one that really you can even look up online from a Joint Commission standpoint. So make sure you know what that requires. And then again, here's some more issues about the flaccid bowel and what you can do to kind of improve that situation. Skincare standards, just